Hi, my name is JP Caneiro. I'm a physiotherapist from Perth, and I'm part of Opus as a postdoc research fellow. Misinformation about the body and pain is very common in our society. There's quite a bit of research that demonstrates that people around the globe understand the body as a machine. And we have examples of people saying, if something hurts, it's often for a reason. It's your body saying, don't do it. Or I believe in nuts and bolts. If something is worn out, you pull it out and put a new part in. So these messages imply that pain is a sign of damage and the damaged part needs to be fixed. So this shapes how people make decisions about their treatment options. And that can be illustrated in this pathway. So the first thing they do, they identify a problem. Then they search for information to understand the problem. Based on that, they evaluate their options. They take action by coming to see one of us healthcare practitioners, and then they evaluate the outcome. So when someone develops knee pain, for instance, the first questions that come to mind is, what is this pain? What are the consequences? And what can I do about it? And of course, this is informed by their social interactions, previous pain experiences, and previous treatments they had. But we know from research that the first port of call for people to try it and look for information about their health and decide about their treatment options is the internet. And if we Google chronic knee pain, NeoWave will come up and it will tell us it's a condition where the cartilage degenerates and breaks down. So these words, they create, they reinforce the belief that the body is a machine and there is a use by date and the parts need to be fixed. So having access to health information at our fingertips is fabulous. And patients consider websites such as government websites, health organizations, and universities as trusted sources of information. However, research tells us that such sources are failing to convey accurate messages about treatment options. They not only talk poorly about the benefits of effective treatments, but they also are not talking enough about the ineffective treatments, such as bed rest for back pain and knee arthroscopy for knee OA. So as a consequence, misinformation can lead to ineffective or even harmful decision-making around treatment options for pain. So if we take osteoarthritis as an example, and this is illustrated by the beautiful work of Sam Bansley and backed up by the work of Ben Darlow in New Zealand, where they did qualitative research and identified that people understand OA as being bone on bone. And that was caused by wear and tear and aging, which leads people to think there's an inevitable decline. So the joint is vulnerable. If you use it, you make it worse. And there is a use by date. So we might as well protect it. So what is the logical consequence? To avoid activities that are not only necessary, but that people value. As an example, people can have this mixed understanding, am I strengthening it or am I sort of destroying the cartilage? So I don't know. So people are told to exercise, but they believe that that damages the joint. So in that confusion, the only treatment options that they have is that exercise cannot replace the cartilage, therefore surgery is their only option. So in order to promote some change in this space, a couple of years ago, a few of us got together and we published this call of action where one of the key steps that we promote is a change in the narrative. So shifting people's understanding of osteoarthritis from a focus on joint damage towards a multifactorial understanding of pain, where multiple factors can interplay to create sensitivity in a body part. Where here we use knee as an example, and then the narrative is shifted towards this joint health, where we focus on what the patients can do and what are the modifiable factors that we can address. There are other initiatives to try to change this digital health landscape and provide trusted health information for consumers and healthcare practitioners. Some of them are My Joint Pain, Pain Health from WA, Glad Australia, Track, led by Christian Barton, and some lovely interactive communication tools, such as this podcast that came out recently and are being widely spread on social media. And these are trying to connect not only with healthcare professionals, but also with consumers and enlightening them with a new view of understanding the body and pain. So a little bit down the line, when patients are coming to see us and they're taking action and they want some answers, and so this clinical encounters become really important. And to build trust in an encounter, it depends on an interaction of not only what we say, but also how we say it. So the content of what we say is the information we provide, the language that we use, which we know is really powerful, and the instructions that we give, but also how we say it, and speaking calmly, expressing empathy, responding to patients' verbal and non-verbal cues, allowing disclosure, and understanding their needs and wants, and considering the patient's agenda and not the practitioner's agenda. And what research tells us is that when patients find that a clinical encounter is meaningful and trustworthy, they have less symptoms, higher quality of life, and a greater engagement in healthy behaviors. So this is some lovely work from Finland, and this is with patients with back pain, but it can be easily translated to musculoskeletal pain in general, where they interview patients and they said, please tell us what you find helpful and what you find unhelpful from these clinical encounters. And they think it's unhelpful when we don't listen to them. We interrupt them often. We give inconsistent information. We provide information they don't understand, so medical jargons. We don't write things down, we just tell them what to do. We are in a hurry and we rush them. We don't follow them up and we provide over-treatment. However, they find it really helpful when we take time to listen to their concerns. We can understand the impact that pain has on their lives. We explain pain using a simple language that is personalized to their level of understanding and contextualized to their needs. We are empathetic and supportive. We summarize things. We provide clear instructions, and we let them contact us. And we put them in charge, where we work as a coach. So it's a very stark difference between these two ways. And it's great to hear what patients want and how they feel heard, and they feel like it's a trustworthy interaction. So what are we doing to promote change in this space? So we've done a small project last year at Curtin University, where we collected data from patients with knee osteoarthritis and also healthcare practitioners that manage patients with knee OA. And we collected some data using the knee OA fear and beliefs questionnaire. And then we took them through an online quiz, which is an active learning approach. So patients were presented with two versions of a video. And these videos were of key concepts such as wear and tear, exercise, weight loss, surgery. And we have two interactions where the participants had to choose or to decide which interaction was helpful and which one was unhelpful. And then they were provided with evidence-based information at a very simple language to inform them of their choice. So here's just a sneak.
Thanks for seeing me, JP. I believe that the pain in my knee is due to wear and tear over the years.
Right, Chris. That's a very common belief. It's an assumption that our joints deteriorate and the pain is coming from it. You brought your scan, and when I look at this scan and I compare to scans that we see from people around your age, it's a pretty normal looking scan. There's a fair bit of evidence to say that if we get people off the street, 100 people off the street, with and without pain, that they will present very similar changes in the scan. So what that means is that pain is not just because of damage in your knee joint. If we look back in your story and the things that you told me, you've been quite frightened of using that knee since you've been told about the wear and tear. You told me that you feel some weakness in that leg. You haven't participated in the activities that you like doing. You used to cycle a lot and you're not doing that any longer. And you also had some stress in your life. So if we look at all those factors, there's quite a bit of evidence to demonstrate that if we get you stronger, we get you trusting that leg, we manage your stress, and maybe even lose a couple of kilos, that can really reduce the sensitivity in your knee.
Okay, thanks.
And the second version.
Thanks for seeing me. I've been told that the pain in my knee is due to wear and tear in my knee. Is that correct?
Right, Chris. Thank you. You brought your scans for me to have a look before. And as you can see here on the scan, it's pretty clear that you don't have a lot of space in this knee joint. There are some osteophytes. There's quite an irregular articular surface. That's the side of the knee that is sore. So it's quite clear from the x-ray that the wear and tear in your knee is responsible for the pain that you're feeling. Okay.
So there you go. After that, patients have to choose what is, is it helpful, is it unhelpful? And they're offered some evidence-based information. And then we collected their beliefs again. So it's a simple design with, and what we could see is that, higher scores indicate more positive beliefs, and the healthcare practitioners, thank God, have more positive beliefs about the knee. But we can see also that both of them changed after going through the active learning process. So what does that mean? It means that we imparted some new knowledge in their minds. Does that transfer to new skills and new behaviors? We are yet to identify that. But what this could mean is that this could be a potential digital learning tool where it creates, it could be embedded in trustworthy websites, and it could provide an example of what a meaningful clinical interaction it is, and patients could then expect or have a greater expectation of what person-centered care they should be receiving when they go and see a healthcare practitioner. So, as we said, misinformation is common, and patients will come in despite all these initiatives. They will come in with lots of beliefs that may be not helpful. Our job is to create a trustworthy relationship with these patients where we can challenge these beliefs and, more importantly, provide alternative options and create a plan to create a change in mindset, but also to give them skills to manage their condition. And to build a trust relationship, what we have to do is to allow time, listen actively, explore the patient's story with interest, be open and genuine about our interest, reflect, repeat, clarify, and inform based on evidence. So thank you very much for your time, and I would like to acknowledge all my collaborators. Thank you.